And Ty, do you have a genetics question?
I was still on mute. I have a question I just asked if Julie would be willing to ask her question. Julie Kermack? Oh. Sorry, we're just
Julie
getting...
Kermack.
Yeah, I chatted an earlier one to you, Julie, as well. So, sorry, just, okay, here we go. We will unmute Julie.
Hi, can you hear me?
Yep.
Yes.
Okay. So my question that I had submitted was, I'm noticing some parents are talking about having had blood sugar issues or still have them, and their kids have HI and are often genetics negative. Is there more research coming with that, or could there be a link between their blood sugar issues and their kids?
Dr. Flanagan, do you want to?
So I suppose in terms of whether there's more genetics possible. So our experience in Exeter is that we, in about 40 to 50% of individuals with hyperinsulinism, where we do exome sequencing, we don't then find a mutation which is causing the hyperinsulinism in these children. But we have there's a range of whether these children are responding to diazoxide or whether they don't respond to diazoxide. So I think even within the group, there's quite a range of phenotypes. There's certainly more research that we can do. I'm not sure whether exome sequencing is always the answer. I think sometimes, as Diva pointed out in her talk earlier, that it's possible that the genetic mutation may just be within the pancreas itself, and we may not then be able to find it if we test the blood. But yeah, there's certainly more research that we could do, and I think there are more genes to find. Yeah, so we are continuing in that way.
Dr. Stanley, did you raise your hand?
Yeah, I was just going to point out that both the Exeter group and our group have a number of families with both a child affected with hyperinsulinism and a symptomatic parent, suggesting there might be a dominant genetic trait that is not picked up by the standard genetic sequencing. So those families are particularly interesting for identifying new genetic genes that are involved with hyperinsulinism. And we have a couple of candidates for that currently in the pipeline, and I'm pretty sure that the Exeter group has a few similar stories.
Okay, thank you.
I have another question here, Julie, an anonymous one. Can a patient with hyperinsulinism have a negative WES test?
So the answer to that is yes. So we've done whole exome sequencing. So this is where we sequence all the genes in an individual to look for the cause of the hyperinsulinism. And in about 40% of our patients, we still haven't found the cause, and it's possible that it's because it's a new cause, and we just need to continue to analyze the data and to try and find new genes. But yes, certainly you can have a negative whole exome sequencing result.
Great. Any other genetics questions?
I have one more that was submitted already. So the individual had a diagnosis, but unknown genetics, and received Russell-Silver syndrome results negative, and every test has come back negative or normal. The upcoming test is exome. Is this the correct test to getting closer to finding out why she has HI, or what test would lead us closer to the big why question?
Dr. Flanagan.
Should I go again? So yes, certainly whole exome sequencing. So I imagine that the child has already had panel testing, which is to test for the known genes, or it could be that they're using the whole exome sequencing as an approach to test for the known genes. But yeah, we should certainly be thinking about exome sequencing in a child who's got negative genetics so far.
I I would add to that's why the assessment has really to be comprehensive, because it's not all the answers sometimes are found by doing more, a whole exome sequencing, phenotyping the child to understand the phenotype of the hyperinsulinism can also guide the interpretation of the genetic testing. So it really should be both genetic testing and a comprehensive assessment of the features of hyperinsulinism. And if there are other non-hyperinsulinism features are also important to be assessed to guide the diagnosis.
Great. Thank you. So maybe, Dr. Flanagan, you can just share with everybody the program that we have for genetic testing.
So the partnership with Chi. So is this, you're talking about the partnership with Chi, Judy?
Yes,
Yeah, fantastic. So we teamed up with Chi actually 2 years ago now. And Chi provide funds for genetic testing for people around the world who would be unable to afford genetic testing either through their own healthcare provider or by personal means. So in Exeter, since the start of the partnership, we've managed to test 399 individuals with congenital hyperinsulinism. And we've found the genetic cause in around 45 to 50% of those individuals. So yeah, if people haven't had genetic testing and it's not available to them through their healthcare provider or through their own insurance, then please get in contact. And we've got a booth actually here, which gives details about how to go about getting the testing.
Thank you so much.
We have one more genetics related question. So I will unmute Karen to ask her question. Go ahead, Karen.
Hi. My question is about finding links to other conditions. So we have a genetic cause for RHI, but my son also has other medical conditions, and I wondered what coordination occurs sort of across the medical fields in terms of finding links to those other conditions. In our specific case, it's inflammatory bowel disease that he has, and they haven't been able to really identify what's causing some of the lesions in his esophagus. So I was just wondering what work's being done sort of across medical fields to link things together.
Okay, is there one of you who feels really well equipped to answer that question? So that means you all do.
Can I just start saying that, we talked about the genetics, and there may be different forms of hyperinsulinism that are not easily explained by single genetic changes. And we see other conditions that are not quite genetic hyperinsulinism. They often have, for a period of time, a degree of hyperinsulinism. So there is a metabolic condition called congenital disorder of glycosylation. So in that case, you often see excess production of insulin. So there are other types of diseases that people try and associate, and I think the more we learn, the more research we do through groups of patients, and I think this is where the growth, the HIV registry is so vitally important, that we kind of bring together various groups of people and study the links. I mean, just one or two patients may not make it, but internationally, the effort that you put in, I'm looking at you, Ty, Julie, that makes a really valuable difference.
Great, thank you. Why don't we move on to focal? I know that there's at least one question in the chat, a focal question. Ty, do you see that? You're on mute.
Sorry. So I didn't have a chance to ask Stevens if he's willing. So just in the interest of time, I will ask the question. So As a cured focal 6.5-year-old son, my son does not seem to have any apparent HI concerns at this time, but we're wondering about what some of the experience have been for individuals that have gone through puberty, as when he had 55% pancreatectomy, Roux Y loop, and gallbladder removal at 2 weeks old at CHOP. There was only about 10 years of this procedure at the time. So essentially the question about should they expect when puberty hits?
Since this is a CHOP patient, Dr. DeLeon, would you like to answer?
Yeah, so we have a long time experience now with Roux-en-Y, and the number of, I don't think that there's anything particular in terms of puberty and concerns with complications. Perhaps what you're referring to had to do with the fact that those children that had more extensive pancreatectomy are at higher risk of developing diabetes or requiring insulin, around pubertal time. When we look at the association between how much pancreas had been removed and the likelihood of diabetes, we found that children that had less than 60% removed are less likely to develop diabetes. So I would say 55% pancreatectomy means that the risk of diabetes later on, particularly at puberty, as you're asking, is very low. In terms of complications about the surgical procedure itself, I don't think that there's anything particular around puberty that is of a special concern. Overall, the number of complications in those patients that had that surgical procedures has been very, very low.
Okay, does anybody want to add? Okay, are there any other questions about focal HI?
We will ask people to raise your hand if you have another focal HI or put it in the chat. I do not currently have any that I am seeing.
Okay, so we will move on.
We've got one in Spanish.
Okay, can she ask in Spanish? And Dr. DeLeon, would you respond in Spanish?
Yeah, I'm happy to do so.
Okay, okay.
Okay, sorry, I need to, the name.
Was it type?
Oh, here we go. Sorry. Okay. I will. Should be all set to talk, Espino. Go ahead, Espino.
Sí, soy yo.
Puede preguntar la pregunta que tiene.
Vale, me escucháis, ¿verdad?
Sí.
Vale. Gonzalo tiene 5 años, nació con hiperinsulinismo congénito focal, tuvo 2 pancreatectomías y en la segunda salió el foco, le medía 11 milímetros y estoy un poco nerviosa ya.
No, está bien.
Bueno, actualmente no tiene tratamiento y se le normalizó la glucemia, pero en una analítica rutinaria para mirar el hierro en sangre se dieron cuenta que tenía 36 de glucemia. Entonces mi pregunta para Diva es, ¿el páncreas no se comporta, aunque esté curado, no se comporta igual que cualquier otro niño? De hecho, no aguanta el ayuno como otros niños, el ayuno nocturno.
Okay. Sí, yo creo que es importante que lo evalúen, porque si el foco fue removido completamente, sí, el niño debe poder ayunar normalmente como un niño normal y no debe tener hipoglicemia. Entonces esto requiere, si el niño está teniendo hipoglicemia, esto requiere una evaluación, incluyendo una evaluación diagnóstica. Es poco común, pero en algunos casos hay más de una lesión. Entonces es importante determinar si el hiperinsulinismo en realidad fue curado o no con la cirugía. Yo les recomiendo que vaya a hablar con el endocrinólogo para que evalúen a su niño.
Vale, ¿él le queda solo el 5% del páncreas o incluso menos?
Sí, yo pienso que es importante que lo evalúen para ver si hay algo de enfermedad residual que necesite tratamiento. ¿Está bien si comparto su pregunta en inglés?
Sí.
Okay.
Sí.
Okay. I'm just going to briefly tell you what the question was. So Espino has a 5-year-old that had 2 pancreatectomies for focal hyperinsulinism. During the second surgery, they identified an 11 millimeter lesion, but she's concerned because he's unable to fast overnight without hypoglycemia. And on a routine laboratory test, the glucose was 36. So my recommendation was that, you know, her son should undergo an evaluation because it is unclear to me if the hyperinsulinism was really cured after that second surgery.
Lo siento. Oh, sorry. So we would like to revisit, Julie, a question from genetics that came up before. I believe Indy was saying that it would be good to revisit the question, how often should individuals check in with their genetics? And so if the panel wanted to, I think Indy was saying he would start, but then we'll let others join in with that one.
I think it's a great question. It's just that technology has moved on that much, and as Sarah was saying in the chat, that new genes are being identified. So if the test had been done 10 years ago, it may be worth repeating, or at least going back to if there was an exome, a whole exome, then it may be worth going back to the data. I'll probably pass you on to Sarah to answer whether it's just, do you revisit the data or do you need to do the whole test once again?
Yeah, I think that I agree. It's worth, I think the first thing to do is to actually check what genetic testing has been done in the first place. I was when I was reading the global registry report, it became clear that quite a few people have just had sort of ABCC8 and KCNJ11 tested and not actually had panel testing. So I think the first thing to do would be to sort of check which genes have been done first, and then sort of in liaison with your endocrinologist, we can think about whether or not exome sequencing would be worthwhile. But yeah, there's certainly more testing that we can do, and things have changed a lot in the last few years. So new genes have been found and new techniques to find things in the genes which we already know about as well. So yeah, certainly worth revisiting.
Great. Okay. So we have a question about feeding. Whether or not feeding issues are common to children with hyperinsulinism. And Jasmine asked the question, or it's about a daughter, Jasmine. Lisa Allgood, would you like to ask your question?
Hi. Yes, so my daughter Jasmine is 2. Can everyone hear me? I'm not sure if I've...
Yes.
Perfect. Yeah, she's nearly 2. She is under Great Ormond Street Hospital in London, previously under Dr. Shah and now Dr. Destamani. And she's had feeding issues in that her orality is very minimal, and this is something that's been an ongoing challenge for us along with everything else as well. And I think it's difficult because it's sort of a vicious cycle, because she's not very hungry because she tube feeds through her gastrostomy for 18 hours a day. So I just wondered what everybody else's experience elsewhere in the world was like with feeding, and if this is a known problem everywhere else as well, and if anyone's been successful in trying something different that maybe we've not tried, that anyone could give any advice on, really.
I can started, but it's a common problem, and we published on this that we recognize that feeding problems can be quite severe in the ones who have quite prolonged illness and a greater degree of severity. I'm not sure exactly what sort of steps, but we work quite closely with a speech and language therapist, and it is not easy. There is a longitudinal trend, but if you keep at it and follow the advice and not get too stressed by it over a period of time, I hope that your child's condition will gradually improve. I don't think there's any magic answer here.
Anybody else on feeding? Dr. Christensen.
Yes, hello. I think it's a very complex issue because there can be so many causes to the feeding problems. Is there brain damage that affects the swallowing and eating? Is there so much hypoglycemia that you cannot allow the child to get hungry? Because if you cannot allow the child to get hungry, then it's very difficult to obtain a normal eating pattern, because you will give on the gastric tube or give too frequent meals, and then you should try to improve the medical therapy to allow a longer time between the meals. But it's very complex and it needs training. We had children who never succeeded to have oral feeding because of brain damage. Others improved from training, but obtaining normal glycemia is a cornerstone.
Do we have any other experts who would like to respond to that? Okay, well, I as a parent will, just to say you are not alone. The feeding issue is one of the most nagging, most horrible issues that we face as a parent, and that double-edged sword of our kids needing carbohydrates more than anything, needing to feed and not wanting to, just leaves us all with the most awful, horrible feeling. And so we feel what you're going through. Those older mothers like myself can tell you that in many, many cases, in most of the cases, the situation vastly improves. And sometimes it takes a lot of time, but it does improve. And for us, going to a feeding clinic was absolutely imperative and really changed things. And tomorrow we're going to have an expert, Dr. Sherry Cohen, who runs the feeding clinic at CHOP and just gives superb advice and has a superb team. And there's nothing more that I could recommend than if you can get feeding therapy. But for a couple of years, we were not able to, and we made the feeding work, but it was just, it was the hardest part of HI. So, and really.
I think Louise also was about to comment on that.
Yeah, I guess I was just going to reiterate it's a problem worldwide with the feeding struggles. And I think, as the other panelists have said, just so many different factors that can contribute, from needing to unphysiologically feed these children at different times of the day and night. I think the medications contribute. I think the actual hormones, the insulin, and I think other enteric hormones that are imbalanced can contribute as well. So I think there's just so many different factors, and I think the feeding clinic potentially trying to use dextrose through the gastrostomy button rather than feed at times can also assist overnight. So I think it's a problem we're experiencing all over the world with these children.
Hi, there's a follow-up. Thank you so much. Do you see it? From Heather and Josiah?
I will bring Heather over. Heather and Josiah, you should be all set. There you go. Oh. All set to talk.
Do you feel that giving overnight feeds, such as Josiah is on EleCare Junior formula, and less D20, that will help his appetite during the day versus having so much D20? We are trying that with Josiah now.
Dr. Thornton.
I think actually the reality is that it's the opposite, that, you know, when you look at the calorie content of D20 compared to the calorie content of the formula, there's less calories. And one of the problems is that in order to keep the blood sugar in the normal range, you end up feeding the child so many calories that they lose their appetite. So actually the less calories you can give at night and the more pure sugar and the less protein and fat, the better you usually do. However, every child has to be looked at individually, and if you failed by, you know, by doing the D20 and you're trying this, you know, everything is worth a try. But for most patients, if we can give the less calories we can give at night, the greater the likelihood they'll eat during the day. But even that doesn't always solve the problem, and it is a very difficult and very distressing chronic problem for most kids with diffuse disease who have persistent hypoglycemia post-op or pre-op.
Great. Thank you. Ty, do you want to ask the next question, please?
Sure. So aside from spikes of hyperglycemia that comes with illness, I have heard from many parents talk about preferring times that their children have a medication dose with a baseline of running a bit on the higher side because they feel safer from lows that way, which makes sense. I've also had the experience that non-specialty centers seem less bothered by glucose running high when it comes to making dose adjustment decisions. I think fear of lows and a sense of safety from DKA can lead to some of us not communicating when we see that, and understandably so. Can you speak to some of the impacts that have glucose values that are consistently higher than the target range may have for people with HI?
Great. Dr. Malikian, would you like to answer that?
Sorry, that was the wrong button. Hi. Well, depends what's really high levels. Is that above 10 or above 8 or above 5? Because many parents, they say we have higher levels and we are scared of those highest levels, and these are actually normal levels, like 5 to 7. So I just wanted to check what's been really high levels of glucose.
It wasn't enough, so I'm not sure if I'll get a specific answer.
It was generally, if you could just address that generally, this whole issue of running higher than normal.
If they have to choose, of course, it's better to have higher than lower levels. And we always try to bring children going up with higher than 4 millimole per liter. And sometimes after meal, we see the level, we see the glucose levels like 8 or 9, and we feel it's safe. So we don't see complications of those high levels. But of course, we need to try and get the optimal levels. I never saw the complications of higher levels in those who was in adjusted doses of diazoxide or octreotide.
Great.
Is that okay as an answer?
It is, but it is. We'd love to hear some other opinions as well. Dr. Thornton.
Yeah, so I mean, there's really a couple of things you have to be concerned about. The first thing is, you know, intermittent high levels that occur with intercurrent illness. And the problem is that when a baby on a medication gets sick, they sometimes get blood sugar levels that are much higher than normal. And we get a little concerned when the blood sugar goes over 200 milligrams per deciliter, or approximately 10 millimoles, because that's the level at which glucose starts to be dumped out in the urine, and the patients can start to get a little dehydrated. So in the short phase, if the blood sugar pops up a little high after a dose of octreotide and 3 to 4 hours later comes back down again, we generally don't worry about that at all. But when the blood sugar is consistently over 10 millimoles or 200 milligrams, you really want to try and reduce the therapy to get those blood sugar down below those numbers, because the babies can get dehydrated. And in very rare cases, they can go into diabetic ketoacidosis, especially if associated with intercurrent illness.
Well, I would agree with Paul. Those cases of DKA have been reported. So if they are running high, we would tend to suggest either dose reduction, or if it was very high, then at least stopping diazoxide or other treatment, at least temporarily under medical supervision. There is a risk that if you run high levels, the HbA1c, which is the longer term sugar control marker, can be elevated, and we just don't know what the side effects are of running very high levels of HbA1c. Is that tending to tip into the complications of diabetes? So I don't really want to risk that. So we should try and keep the levels in the normal range as far as possible.
I would add to that definitely fine-tuning of the treatment is very important, and to emphasize that it's probably a false sense of security that having high numbers is safer for the kids, in the sense that, if your therapy is not adjusted and the glucose, particularly for children that have diazoxide responsive and are running high all the time, many times the lows that you see are post-high. So the high numbers can trigger more episodes of hypoglycemia. So a lot of fine-tuning needs to be done to try to get the glucose levels as close to normal as possible in both ends.
Well, thank you so much for answering that. And, the question was so good, because it's really a very common theme that those of us, many of us especially, that are not diazoxide responsive, that are on octreotide, there's a big fear of lows. And so we have that insecure, wrong secure feeling. We should feel insecure, but we tend to feel more secure when the sugars are a little on the high side. And so hearing that we really need to go for normal is really good for us to hear, because it's so common for us to fear lows and prefer highs. Ty is going to ask a question in a second, but before she does, we do have an expert on pancreatic cells with us, Dr. Mark Dunn. So while Ty is reading the next question, if there is somebody out there who has a question about beta cells or some other kind of pancreatic cell, this is a great opportunity to ask your question. Okay, Ty.
Great. So in the anonymous chat, we have one. My son was diagnosed at 1 month old. He was fasted for hours and showed no sign on low glucose levels. Once he was given formula, his glucose level dropped to the point that he was given a glucagon injection. He eats every 2 hours, even at night. His pediatrician told me recently to stop feeding at night, and I did, and the same thing happened. His glucose level dropped to the low 40s after fasting and then been fed. He is now 4 years old. Is this because he now needs an increase in his diazoxide medication?
Okay. Let's see. Dr. Dustamani, would you like to answer that?
He needs reassessment under a control fast of his fasting tolerance to see exactly at the age of 4 years what's his fasting tolerance on the current dose of diazoxide that he's on, and what is the response from the ketones point of view, and then to decide if he needs further increase of the dose of diazoxide. But definitely he needs a control fast under medical supervision in order to conclude that and give the right advice.
One of the other things that the family might want to think about, especially, you know, the report that sometimes when he eats the formula, it makes him go low, is could that child be protein sensitive? So in addition to a fasting study, it might be worth doing a protein challenge and just see that is there a specific food type such as protein that triggers lows during the day, or is it just fasting induced from the length of time that you're not eating? And so that's why it's very important to follow up with your specialist, do your, you know, annual or every 2-year tune-ups in the hospital where all these different things are evaluated and a plan can be put in place for the next year or so.
Great. Any more comments or responses? Okay, we'll move on to the next question. Ty.
So Julie, we had a question in the chat for Mark. Maybe not what you were expecting, but we can go with that. So I'm allowing Karen to speak.
Hi, it's me again. I have a 5-year-old with PMM2 genetic mutation, and when his brother was born, we banked cord tissue and cord blood, and I was wondering if there's been any research into stem cell therapy or treatment for the pancreas.
Hi Karen, there has been research on stem cells and deriving stem cell lines more for research purposes. There's a group out of Beijing and Zhang Zhu who published a couple of years ago on engineering a mutation in the ABCC8 in a stem cell line for research purposes. We also published quite recently an inducible pluripotent stem cell line that was derived from a patient with hyperinsulinism. So these, and Timo Tonkoski's group in Finland is also working quite heavily in this field. I think it's really more as a research tool at the moment. In the future, as for people with type 1 diabetes, that there is always the aspiration that we may be able to reproduce beta cells in patients in order to cure diabetes, but these kind of translational approaches are quite a long way away at this stage. So yes, for research purposes, but not for clinical needs at the moment. Thanks for your question.
Yes, Dr. Thornton.
Sorry, I just wanted to add a word of caution. I see a lot of people are starting to ask questions about dasiglucagon. When your child is in a study, like something like dasiglucagon, we really shouldn't be talking about the results of the study because it can taint the study. So if the people who are asking questions about dasiglucagon maybe might not do so, it would be better overall for the study. Sorry about that.
Okay. Okay, Brian Mathis has a question, Ty. You're on mute.
All right, am I off mute?
No,
That's
you're
better.
good. We hear you, Brian.
So I had, my question is about Sam, who's 5 years old, and he's as well controlled as we could ever possibly like. He came in at 4 months, and at 5 years, he's very well controlled. And so what are the odds of him sort of outgrowing it? His dosage has gone down from 15 mg per kg down to 10. So it's slowly going down over the years, but at the same time, he definitely needs that dose. So what are the odds of him outgrowing it? And is this something that we're likely to see him move into adulthood with?
Dr. Banerjee, want to give that a try?
Yeah, I mean, there is a longitudinal reduction in severity that we recognize in every country. That doesn't necessarily mean that the disease is going away. we've seen that there is a gradual reduction in the need for a bigger dose of diazoxide. But as you say, your child is still needing about 10 milligram per kilogram. So there is still a persistent need. And in some children and young people, we see them needing as lower doses for a 5 milligram per kilogram, and that carries on even beyond childhood into young adult life. Whereas others, they gradually can come up. What we don't know is what happens when, say, in adult life, they are pregnant, this is obviously women, whether that comes back. So there's a lot of unknowns. I think at the moment, it's very finely balanced. All I can say is watch and wait, and let's individualize the treatment to your child.
May I add, we had observed sometimes patients with 2 milligram per kilogram, and when we stopped the treatment, hypoglycemia reoccurred. So you cannot really forecast if 10 milligram goes to 5 milligram and goes less than. It might be necessary to give a small amount for a very long period. Although mostly if you are below 5 milligram, you can expect it will go without, but you cannot be sure. And I remember a lady who was treated until her pregnancy when she was 25 or something like this. And then she stopped diazoxide, and she got 3 days later a hypoglycemic seizure. So I think it's more statistics than for the individual case.
Dr. Stanley, did you have something you wanted to add?
Well, I was just going to comment that I think, as Diva pointed out earlier, it's very important to thoroughly analyze each patient for the type of hyperinsulinism, the genetics, the particular phenotype, and the ability to come off diazoxide is very much dependent on the underlying genetic mutation there. It's unlikely in patients with HIHA that they can come off diazoxide. I've seen adults as old as 40 or 50 still requiring diazoxide. So it depends, as people said, it has to be individualized for each patient.
Well, thank you all so much for asking questions, and thank you experts for answering the questions. This is just day one of the conference. Tomorrow we have another Ask the Experts session that will be more focused on research, what's going on in the biotechs, what's going on in the academic institutions, and hopefully our breakout rooms will work tomorrow. And if they don't, we'll come up with a solution and idea before we start, so we're organized. And now we have a really, really big treat, and it's a song called Down and Up. It's a music video made just for you. So Jana, are you here with your video?
Yes, hello again, everybody. So I'd just like to introduce myself again. For those who don't know me, I'm Jana Pell. For those who do know me, I'm still Jana Pell, and I am Chi's Creative Communications Specialist. And, oh, somebody, okay, it says unable to start video, you can't start your video, oh, and it's fixed already. Okay, take two. So in addition to working for Chi, I also work with a children's music initiative. And, you know, a few months ago when COVID was just beginning, I was, you know, scrambling to find feel-good content for social media. And one day I had an idea for a kid's song about hyperinsulinism. So I texted Julie a voice memo. It was just the chorus and me playing guitar at the time. It was like 30 seconds long. And with the help of Julie and my Chi teammates as executive producer of this song and video, as well as many of you in the Chi community, you may remember we posted on social media and crowdsourced inspiration for the lyrics and asked for calls for photos of children checking their own sugar. And today we are just so excited to share the finished product with you. So without further ado, please enjoy Down and Up, dedicated to everybody on the HI roller coaster.
If your sugar's low and your insulin's high and you don't know why, it might be HI. If your sugar's low and your insulin's high and you don't know why, it might be HI. Sugar goes down, 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 so we gotta bring it up, up, up. Sugar goes down, 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 so we gotta bring it right back up. Most of the time, sugars are fine, but sometimes it goes low. You could be running or playing or dancing around, but sometimes we just don't know. Yes, sometimes it takes us by surprise, but we've got mommies and daddies by our side, holding on to us for this roller coaster ride. So if sugar's low and your insulin's high and you don't know why, it might be HI. If sugar's low and your insulin's high and you don't know why, it might be HI. Sugar goes down, 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 so we gotta bring it up, up, up. Sugar goes down, 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 so we gotta bring it right back up. You could be swimming or jumping or hanging around, reading or watching TV. A G-tube feed, a cookie or some Cheez-Its is usually all you need. So we check sugars just in case. It's not convenient, but it's safe. Down and up and up and down, won't stop till a cure is found. Down and up and up and down, won't stop till a cure is found. So if your sugar's low and your insulin's high and you don't know why, it might be HI. If sugar's low and your insulin's high and you don't know why, it might be HI. Sugar goes down, 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 so we gotta bring it up, up, up. Sugar goes down, 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 so we gotta bring it right back up.
Well, thank you so much, Anna. I hope everybody really enjoyed that. And I'm very sorry for the technical difficulties. We will have that available to all of you very, very soon. And you'll be able to watch it and watch it again and watch it with your kids. My whole family is just singing it all the time. We can't get it out of our head. We love it so much. And tomorrow, Jana will perform it live for us on the, here at the conference. So we just want to say thank you so much for joining us. And now you have until 3 o'clock to visit all the incredible booths. You can actually visit them way past 3 o'clock. They'll be open for 7 days, but there will be technical assistance until 3 p.m. But they're really, really great. So we really encourage you to take a lot of time in the booths. Everybody who made their booths spent just an incredible amount of time and has put in wonderful information. And I think some of the experts might even be available at their booth, or you can sign up to talk to the experts. So it's really a great opportunity. Our sister organizations have great materials. A big shout out to the Children's Hyperinsulinism Charity for publishing a children's book that just looks so adorable. And we have the ever talented Uli Seyfarth from Berlin, who has wonderful materials at her booth, and Christina Pindado, who has great materials in Spanish at her booth. So go visit, have a blast, come back tomorrow. The auditorium opens at 10:45 a.m. and we'll start the morning session sharp. Thanks so much. Feel free to give us any feedback you want. We're still stuck in our houses because of COVID all afternoon and evening, so we're available. So have a great, great, great rest of your day, your evening, middle of the night if you're in Australia, and we can't wait to meet up again tomorrow. Bye-bye.